Hello there. My name is Dr. Rebecca Gilbert, and I am Chief Scientific Officer at American Parkinson Disease Association. Thank you so much for joining us for our Dr. Gilbert Host series, during which we are discussing important issues regarding the COVID-19 virus and how it has impacted Parkinson's disease patients. American Parkinson Disease Association, or APDA for short, is the largest grassroots network dedicated to fighting Parkinson's disease and works tirelessly to help the approximately 1 million people with PD in the United States live life to the fullest in the face of this chronic neurologic disease. Please visit our website at apdaparkinson.org to explore all that we have to offer. This includes programs and services delivered by our network of chapters and information and referral centers located throughout the US. Through this network, you can gain access to support groups, exercise programs, and educational symposia in your area, and we are now offering many programs online as well. Our website also hosts a vast array of publications, webinars, articles, and information that can help you understand your Parkinson's disease. Another way to contact APDA is through our toll-free helpline, 1-800-223-2732. And now for today's program. Today, we will be discussing deep brain stimulation, a surgical treatment for Parkinson's disease, and COVID-19. Many patients and their care partners have specific questions regarding how deep brain stimulation can be best managed in this era of social distancing. My guest today, who will help us answer some of these questions, is Dr. Jill Ostrem. Dr. Ostrem is Medical Director and Division Chief of the UCSF Movement Disorders and Neuromodulation Center. Dr. Ostrem is a movement disorder specialist with a focus on improving diagnosis, experimental therapeutics, and technical innovations in the surgical treatment of movement disorders. She works to develop improved deep brain stimulation systems, which are implanted devices that deliver electrical impulses to treat movement disorders, and investigates optimal deep brain stimulation brain targets. She also studies innovations in patient care, including telehealth, which is the providing of healthcare through advanced technologies, and new models for palliative care. Dr. Ostrem earned her medical degree from the George Washington University, and she completed a residency in neurology and a fellowship in movement disorders at the Ronald Reagan UCLA Medical Center. After joining UCSF in 2003, Dr. Ostrem helped establish an internationally recognized clinical research and training center for the treatment of movement disorders. Now we have a whole bunch of questions that have been submitted earlier that we will be discussing with Dr. Ostrem, but we very much want to hear from you who are currently listening as well. And if you are watching this live and you have a question, please feel free to enter it using the question and answer feature in your Zoom app. And right now, we are, Dr. Ostrem, are you with us? So it looks like Dr. Ostrem may have dropped off momentarily, and we are going to wait for her to return. So in the meantime, I will give a brief overview of what deep brain stimulation is. Deep brain stimulation, as already implied, is a surgical treatment of Parkinson's disease in which a small wire is placed deep in the brain and sits in specific structures that are part of the Parkinson's disease circuitry. When these specific structures are stimulated by electricity, the Parkinson's disease abnormalities in these structures can be overcome. And deep brain stimulation is a well-established treatment that has been approved for use in Parkinson's disease as well as other movement disorders for about 20 years now. Dr. Ostrem is back with us, which is great. I just gave a brief overview of what DBS is and the fact that its use has been very, very helpful in a subset of patients with Parkinson's disease for over 20 years now. And it is a treatment that Dr. Ostrem is well-versed in and is an expert in. And so we will take a couple of questions. We'll start with the first one, which is, my symptoms are worsening, but I can't come in for a visit right now because of social distancing. Can my physician manipulate my deep brain stimulation system remotely? So Dr. Ostrem is still muted, just getting up to speed. There you go. So you heard the question, Dr. Ostrem? I can't come in for my visit right now. Can my physician manipulate my deep brain stimulation system remotely?
Yeah, hi, good morning. Thank you so much, Rebecca. Can you hear me okay?
Yes, we gotcha.
Okay, it's lovely to be with everyone remotely this morning. I really appreciate being invited to participate in this forum. It's a new way to communicate. There's a lot to talk about with regard to DBS and how we think about managing during this difficult time. It's a really good question that you bring up, and I think that's on a lot of patients' minds that I'm caring for, I know. If you are struggling with some of the symptoms that you're having now, and you're at home and you're worried, I would encourage everyone to really reach out to the physician that's taking care of you, and see what kind of care they're able to provide for you during this time. A lot of the centers are offering telemedicine visits now, so that you can have a video like we are right now with your provider, and they can help you think about ways that your medications might be optimized. They can help you to walk through kind of a way to check the deep brain stimulation system with them on the video. And that's been a very successful way in which we've been able to kind of manage people through this difficult time. And I would say that that's maybe not available everywhere, but if it is, it can be a very helpful way to think about working with your care providers and your device.
All right, sorry. The next question, which is a companion question to the first one, is, can I manipulate my own deep brain stimulation system at home to help with my symptoms? You alluded a little bit to this, but could you elaborate on what a person can do with their own device at home?
Sure. Yeah. Some of the systems, all of the commercially available DBS systems right now in the United States allow for some adjustment to stimulation parameters to be made with the patient programmer. So one thing that you can do with your patient program is to turn on and off your device. I think that's true for all of them. But some of the systems can also be set up to allow for adjustment of variables. Usually it's something like the amplitude of stimulation, so the amount of stimulation can be increased or decreased. And the systems allow for sometimes if they've been set up this way, to go between different groups or programs. So this is something that needs to be set up in advance by the physician or the programmer that you've been working with. And if those weren't pre-specified, in advance, and it hasn't been set up that way, you wouldn't be able to make adjustments. But in many people, it is. And so if that rings true to you, if that sounds like something that your physician talked to you about, I would like you to try to go home, and why don't you increase a little bit, over a certain window of time, or try these different groups or programs and see which one works best for you. If you don't know what I'm talking about, you probably don't have this set up in your system, but if you do, it is an option for you to think about exploring those things if you think it would be helpful. You need, again, be nice for you to check in with your care provider to know, or your physician to know what would be the appropriate way to go.
Okay, thank you very, very much. We have a couple questions coming in which are more general to the topic of DBS and not specific to this time period, but we'd like to answer them. There's a question from Frank, and he asked two questions. What is the upper age for people to get DBS? That's question number one. And question number two is, I've heard that DBS can negatively affect speech. Can you elaborate on whether this is true, and are there settings that can mitigate those effects?
Sure, both great questions. Yeah, there's no, in my mind, no upper age. Of course, the risk of deep brain stimulation complications is going to be higher for someone with an advanced age. We get a little more nervous about applying deep brain stimulation therapy and having people go through the surgery if you're, you know, in your upper 70s or 80s, but it's not unheard of. So it really depends on the type of physical health that you have and your symptoms that you're experiencing. So really something that I wouldn't say there's a cutoff age, you know, that is not how we think about it anymore. And then in terms of the other question, yes, deep brain stimulation can have an effect on speech. It generally does not help to improve speech very much. You know, a lot of Parkinson's patients will have hypophonia, the soft speech. It doesn't generally help to improve that. And in some cases, it can make speech worse. And usually that's because of stimulation that is spreading outside of the area we would typically want the stimulation effect to be impacting. And so by adjusting the stimulation settings, which is even easier to do now with some of the new technology that allows for more steering of stimulation, you know, the risk of that seems to be less. But it is an important thing to understand that it is a possibility that in some patients we do see some worsening of speech, and we're still trying to understand exactly how to mitigate that.
Excellent, thank you. And then we have another question, and this is from Victoria. I've had DBS, but I'm not convinced that I'm programmed correctly. It's about a year later. What are the reasonable expectations from a DBS? Some people seem to have better results than Victoria was hoping for. What can we tell her?
Yeah, thanks for the question, Victoria. So I think it's hard to say for sure what's going on in your situation without more detail, but certainly, you know, Parkinson's disease is incredibly diverse kind of condition, right? And some people will have tremor, other people will have problems with their gait, some people will have severe motor fluctuations and dyskinesia, some people will have all of those things, and it can be hard to know exactly how much benefit you'll get from deep brain stimulation in any one individual. One way we try to predict this is by doing what's called the on-off UPDRS, when you come in off your medications and then take your medications. And in the clinic, we can get a sense of how much the medication is helping that individual. And it helps to give us a sense of how much benefit deep brain stimulation might provide. But that being said, there's certain symptoms that deep brain stimulation improves more than others. Certainly it can help improve tremor quite well. It can improve motor fluctuations. It can improve dyskinesia. It can allow you to lower your medications, but it doesn't often improve your cognition, your balance, your speech, like we just talked about, as much. So it kind of depends on what the symptoms are you're still struggling with to know whether you've been optimized with your programming or not. I think it's a good thing to talk to your doctor about and see what they have to say. It's always interesting to turn off, not saying you do this, but you can always turn off the DBS, and that can remind you, you know, of the benefit or not that you're getting. I wouldn't do that right now, especially in a pandemic. You don't want to be doing things like that. But it's never a bad idea to explore just the, you know, to see that you're getting the most out of your DBS as you can. So the great thing about deep brain stimulation therapy is it's adjustable. And there's a lot of different programming settings that can be used and tried. And so, you know, if that hasn't really been explored fully, it's worth doing.
Great, thank you so much. We have a question coming in our Q&A box, which you touched on before, but I just want to kind of readdress it as well. I have DBS and my symptoms are worsening. I know for sure I cannot adjust it by myself. What should I do? Are there any specific steps that this gentleman should take to help him right now?
Yeah, I mean, if you can't adjust the deep brain stimulation at all yourself, I'm wondering if he's saying that because he doesn't know how to interface with the patient programmer, or if his device is not set up to allow him for patient adjustment. So I guess it depends a little bit, but you can make changes to your medications, and sometimes that can be very helpful during this time when we don't have as much access to our physicians in person. So I think that would be, another way to explore trying to improve his symptoms, at least temporarily, by making adjustment to medications right now.
Great. That's a very very good point. So not just dealing with the DBS program or neurologist that you may interact with, but your general neurologist can be very helpful. We have had a few questions that came in about the surgery. So many hospitals are limiting surgeries to urgent cases. Patients with Parkinson's disease who have a DBS in place may require battery replacement during this health crisis, and they may be anxious that they will not be able to get this surgery. What is your experience with this type of issue? What should a person do if their DBS replacement was scheduled during this time, or if their DBS battery starts to run low during this time?
Yeah, lots of good questions in there. I'll see if I can unpack that a little bit. Yes, in this day and age, a lot of hospital systems are not allowing for elective procedures. So deep brain stimulation in general is classified as something that's non-urgent. It's elective. It doesn't need to be performed within the week, etc. And so a lot of hospitals have been canceling elective procedures to allow for patients with COVID-19 and the resources that require, for them to be cared for in the hospital a priority. However, we're now seeing a lot of hospitals, including where I work here at UCSF, opening up a bit and thinking about the fact that, we have not, at least here, had as much of a surge, thank goodness, as we had planned for. And so we're starting to see other sorry, still there?
Yeah, okay, we're good. We gotcha.
Starting to see things change here now, and I would still caution folks thinking about having a deep brain stimulation surgery. I mean, I think you really need to work with your local system and find out what kind of access you have to the hospital. It will not likely be the same, at least in the near future. I know, there may be regulations on how many, not allowing having your family members come to the hospital, etc. Having a testing for COVID-19, things like this are now being put in place for elective surgeries. But that being said, I think we'll start to see some happening. They'll just probably be done in a limited way. If you need a battery replacement, this is maybe a more common scenario right now. And I think, again, those procedures are being done probably in a less, in a fashion that's a little bit more spread out and more thoughtful. I think the patients who really have a low battery or who, if their battery were to die, their symptoms would be very severe. Those are going to be the cases that are going to go first. And then they'll be doing the others. So I think it's really important to be in touch with your neurologist, your neurosurgeon, the team that would replace your battery, if you feel like you're in a situation like that. And you can certainly check your battery level yourself by using your patient programmer, and you can determine how full the battery is. Many people have rechargeable batteries now, which is great. So they don't require a replacement as often. But for the more traditional non-rechargeable batteries, you can use your patient programmer to check. And for many of them, it's very clear when the battery is declining. There's an alert that comes on the screen. So you can then, if you see that alert, give the practice a call that's managing your system, and they can help you figure out when an appropriate time is to have the battery replacement.
Fantastic. We have an excellent question that has come in through our Q&A box. And this is something that's a general question, but I think it's appropriate to talk about it now. Is it valid for people with Parkinson's to tell their doctor what device they want? Boston Scientific versus Medtronic versus Abbott. There is marketing that patients with Parkinson's may be experiencing, and how do physicians make a choice about which device to go with? And what role does the patient play in that choice?
Yeah, that's a great question. I would say, as a patient, you certainly have a voice. You should ask questions. You should, and if you feel like you're fully informed about the various devices and the features that they offer, and you have a preference, you should voice that, I think, to your team. Your team may have a choice that they recommend too. And they should then explain to you why they feel that way. And they may, and it may align or it may not, but all the devices are excellent. They're actually very much more similar than they are different. I think it's important to work, I think it's important to have your team be comfortable with the device that you're being implanted with. So that's something that you would want to, I mean, hopefully they all are, but like if you can imagine a situation where neurosurgeons only ever worked with one of the devices, you might not want to be the first person to get a different device. You know what I mean? Otherwise, I think it's a good conversation to have, between you and your team. That's the basic way I think about that scenario.
Excellent. We have another question coming into our question and answer box. Should I try duopa first? So duopa, for those who don't know, is a system where levodopa, one of the medications for Parkinson's, is infused directly into the small intestine via a pump, and the patient wears a small pump that they carry around with them. And there is a hole made in the abdomen, and the tubing is threaded into the small intestine. So that system is also a slightly invasive procedure where a hole is made in the abdomen versus the surgical procedure in the brain. So should I try duopa first as a potentially less invasive procedure before trying DBS? That's the question.
Yeah, great question. I think both are good options. There's no reason you have to try duopa before DBS, or vice versa. You don't have to have DBS before you have duopa. They're both therapies that are useful for advanced disease management, or even moderate disease management in some patients. And they're different. They have different risks. They have different burdens to them. So I wouldn't say that they should be used in sequence. I think you can think about them at the same time and then determine what you think would be most appropriate for you and your symptoms.
Okay, fantastic. And now we have another question. What happens when a person with deep brain stimulation goes to the hospital with suspected COVID-19? Does a general emergency room staff know about deep brain stimulation, and do they know how to handle people with deep brain stimulation? This can be a general question, really. If a person goes to the hospital with DBS for any cause, what is your experience about the hospital staff understanding their deep brain stimulation?
Yeah, it's a great question. And I think it really depends on probably where you live and what kind of hospital system you're working with. I would say in more recently, I think we have greater understanding from our emergency room colleagues of deep brain stimulation, but is still probably less recognized than certainly all of us would like. It's important to bring your patient programmer with you. And sometimes, if the emergency room staff is not familiar with DBS, you can then show them what the patient programmer looks like. If there was some reason they wanted to turn off the DBS temporarily, let's say you need an EKG and your DBS is giving an artifact, you could temporarily turn it off for, a couple of minutes, do the EKG and then turn it back on. There might just be other questions that they have regarding the DBS. So being able to have some way to interact with the DBS to ensure that it's on or off without them having a physician programmer in the emergency room. So I would recommend taking that with you. Other than that, there's a lot of information you can get from the companies that help support these devices, and a lot of that's available, through website or through 1-800 numbers. So those are resources as well for the emergency room. I wouldn't be worried about going to the emergency room if you need to, and you have DBS. I would go, but I think bringing your patient programmer with you is a good idea.
Great. So a companion question is, what about MRI? So I think people may be aware that the restrictions on having an MRI with DBS have changed. for many of the devices over the past short while. Can you comment on the use of MRI for DBS when a person has DBS in place?
Correct. Yeah, there is now MRI restrictions that have been lifted. There's a way in which an MRI has to be done to be compliant with the way in which it can be done safely with the current guidelines. So again, I would take your patient programmer with you when you go to the hospital or to have an MRI. Generally, it depends slightly about what kind of a device you have. But in general, we like to survey the system, the DBS system, before you have an MRI, usually within a week before, to make sure that there's nothing electrically going on that's gone awry, or there's anything that might indicate that the system is compromised. And also think about placing the MRI into a different setting, potentially, if that's safer. So there can be some very specific things that need to be considered before having an MRI. And you need to work with your healthcare provider to ensure that those things are kind of done beforehand. But a whole body MRI is now available for most of the systems. So that's great news for patients.
Excellent. Thank you so much. So now a question. What if my system turns off inadvertently in my house for whatever reason? How can I turn it back on?
Yeah, great question, and really important. And if you're not sure about that, that's one thing you really would be great for you to understand, because this can happen. It used to happen a lot more with some of the older devices, but still, even today, it can happen. And if you're changing your settings on your DBS, you can hit a button incorrectly, and it can turn off erroneously. So if you're really feeling terrible and you have no other explanation, and you have DBS, first thing to check is just to make sure it's on. And both sides are on. Sometimes people have two different independent systems, right? So it's generally very easy. Again, it depends on the type of device you have, but get your patient programmer, turn on the programmer itself, and then usually the first thing you see on the screen is either on or off, and that indicates whether it is on or off. So you can check your patient manual. You can go online if you don't have that anymore for some reason. You can call Medtronic. You can call your care providers, your neurologist, and they can help you walk through that too.
So there is quite a bit you can do with that patient programmer. So getting to know that patient program is very important.
It's really important, Rebecca. Yeah, right now, especially knowing whether it's on or off. I mean, that is something you can definitely make sure you have, if you have the Medtronic, make sure there's new batteries in it, or make sure the other systems, Abbott or Boston, they're charged. But otherwise, it should be pretty straightforward in terms of knowing whether you're on or off.
Excellent. So we're going to take one last question, and then our half an hour is over. So that happened really quickly. My DBS surgery is scheduled for the summer, and I have a lot of testing to prepare for it. So I have my MRI scheduled for next week, for example. Should I be leaving my house now to get these preparatory tests?
Yeah, great question. And I guess I'm sorry to keep saying you have to go, and ask your local team, but it's really true. I think there's just such different practices in place right now across the country. At least that's my understanding. And some systems are probably not doing very many MRIs if they're not urgent. Other places might be. So I would feel like they wouldn't, for this person at least, if they needed an MRI and they'd ordered it, if you've been scheduled and they're recommending you come in and get it, I would follow those recommendations. And for those of you where the system doesn't have the resources, or they don't feel like it's safe, you won't be scheduled. So going with the team and their plan is the best recommendation I can give, I think, at this time.
Fantastic. Excellent advice. So for any questions that came in that we were not able to answer during this session, I will be sending you emails, so don't worry. Your questions will be answered. And I want at this point to thank Dr. Ostrem so very much for joining us today, for all your valuable insights. And if you missed part of this session or want to share it with someone else, a recording will be available on our website at apdaparkinson.org in the next few days. So check back and you will be able to access that. Make sure to join us for our additional sessions of Dr. Gilbert hosts. Next Monday, May 4th, I will be hosting Kathy Thomas for a conversation about medical management and the era of COVID-19. And on the following Monday, May 11th, I will be hosting Dr. Joel Perlmutter for a discussion of Parkinson's disease research in the era of COVID-19. And you can register for those sessions on our website as well. Please consider at this time to donate to APDA to allow us to continue to bring this type of programming to you. And once again, you can donate at apdaparkinson.org. So thanks again so much to Dr. Ostrem, and we hope to see everybody on our future programming very soon. Have a great day.